Welcome everyone, my name is Dr. Husameldin Muhammad Ali. I'm an ECFMG certified physician, and I scored 270 on Step 2 CK. I run an education platform called Navigence, where we focus on simplifying complex, high-yield topics for medical students and residents. Today's presentation is all about Pap smears and cervical conditions, a topic that often creates confusion because different resources sometimes give different answers. I've built this session using UWorld, AMBOSS, CMS forms, and Divine podcasts, and combined them into one clear roadmap. This is especially important because every Step 2 CK exam contains at least 5 questions in this area. The examiners know it's an area of conflict, and that's why you need a structured, integrated approach. In this session, we'll cover everything from screening to management, best next steps, and treatment strategies. So by the end, you'll have a complete A to Z understanding of cervical cancer screening and related conditions. By the end of this session, you will be able to understand the embryological development and histological features of the cervix, explain the origin of Nabothian cysts as a developmental outcome, recognize why gonorrhea screening is recommended only until age 25, recall the official Pap smear screening intervals and guidelines, identify the risk factors, diagnostic confirmation, screening options, and management strategies for cervical dysplasia and carcinoma in situ. And finally, outline the approach to invasive cervical carcinoma. As you may remember from Step 1, sexual differentiation begins with the SRY gene on the Y chromosome. The SRY gene activates testis development. The developing testes then secrete Müllerian inhibiting factor, MIF, also called anti-Müllerian hormone, AMH. MIF causes regression of the paramzonephric, Müllerian, ducts, which would otherwise form the female internal reproductive organs, fallopian tubes, uterus, upper vagina. So the key concept is that in the absence of MIF, the default pathway is female internal genital development. The paramzonephric ducts develop on each side and then fuse in the midline to form the uterus and the fallopian tubes. During this fusion, a midline septum forms and normally degenerates to create a single uterine cavity. If this process fails, conditions such as a persistent uterine septum or a bicornuate uterus can occur. These are important causes of recurrent pregnancy loss, but we'll cover them separately later. The paramzonephric ducts also contribute to the upper one-third of the vagina, which is mesodermal in origin. The lower two-thirds of the vagina arise from the urogenital sinus, which is ectodermal in origin. Now let's see the histology connection. Structures from the same embryological origin share the same epithelial lining. At birth, the uterus, cervix, and upper vagina, mesoderm-derived, are lined with columnar epithelium. The lower vagina, ectoderm-derived, is lined with squamous epithelium. After birth, exposure to the vaginal environment causes metaplasia of the ectocervix and upper vagina into squamous epithelium, which is different from their embryological origin. The cervix has 2 distinct epithelial regions. 1. The ectocervix, which faces the vagina, is lined by stratified squamous epithelium. 2. The endocervical canal is lined by columnar epithelium, arranged in folds known as crypts. The junction between these 2 epithelia is called the squamocolumnar junction. Over time, the squamocolumnar junction shifts its position due to hormonal and environmental influences. The area between the original squamocolumnar junction and the current squamocolumnar junction is called the transformation zone. The movement of the squamocolumnar junction happens mainly due to hormonal influences, especially during puberty and pregnancy. Initially, the endocervix is lined by simple columnar epithelium. When this tissue is exposed to the vaginal environment, it undergoes squamous metaplasia to adapt. This creates the transformation zone, where columnar epithelium is gradually replaced by squamous epithelium. Note it is different from the squamocolumnar junction, and in fact it is the zone between the original squamocolumnar junction and the new squamocolumnar junction formed after the change in its position. The columnar epithelium of the endocervix contains deep folds and crypts. Sometimes during the metaplastic process, squamous cells can grow over the surface of these crypts and enclose it. The mucus-secreting columnar cells inside down the crypt remain active, but since they are now covered, the mucus gets trapped. This results in the formation of cysts, which is called Nabothian cysts. Nabothian cysts are a benign cysts that forms when squamous epithelium overgrows glandular columnar epithelium in the cervix. Most of the time, these cysts are asymptomatic and discovered incidentally during routine pelvic exams or pap smears. Rarely, they can cause pelvic discomfort, pain, or a sensation of vaginal fullness if large. Treatment is usually not required. However, if symptomatic, they can be managed with simple ablation or cauterization. Please note, these Nabothian cysts are benign, not precancerous. Their main significance is distinguishing them from pathologic lesions on exams and in clinical practice. In women of reproductive age, the columnar epithelium can sometimes be seen on the ectocervix as a circular, red area around the external cervical os. This is a normal finding and should not be called cervical erosion, because that term incorrectly suggests an ulcer. The correct term is cervical ectropion. Cervical ectropion often develops under the influence of the 3 Pia seconds, puberty, pill, hormonal contraception, and pregnancy. It is a physiologic change, not a pathological lesion. The columnar epithelium of the cervix is more susceptible to bacterial infection and colonization compared to squamous epithelium. During puberty, cervical ectropion increases, exposing more columnar cells, which is why sexually active adolescents are routinely screened for gonorrhea up to age 25. Screening usually stops at age 25 because the ectropion decreases with age, reducing susceptibility. Now let us move forward to discuss pap smear and colposcopy. A pap smear involves collecting cervical cells to screen for cytological abnormalities. It is performed after direct visualization of the cervix with a speculum. Cells are collected from the transformation zone using a cytobrush or spatula. A colposcopy is usually done after an abnormal pap smear or a positive HPV test. The clinician applies 3 to 5% acetic acid to the cervix. Abnormal cells appear white, ace to white, because they reflect light differently from normal tissue. If abnormalities are seen, a directed biopsy is taken for histopathological confirmation. So pap smear is a screening tool, but colposcopy with biopsy confirms the diagnosis. Cervical cancer screening starts at age 21, ages 21 to 29. Cytology, pap smear, every 3 years. Ages 30 to 65. Options include cytology every 3 years, co-testing, cytology plus HPV, or HPV testing alone. The latter two, which are HPV-containing tests, are preferred. Special populations are HIV-positive patients, which start screening at onset of sexual activity, or at HIV diagnosis, whichever comes first. Screen annually until 3 consecutive normal results, then follow routine guidelines. And immunosuppressed patients, including those on immunosuppressants, begin screening at sexual debut with pap smear plus HPV co-testing. Reflex triage testing is a strategy, primarily used in cervical cancer screening, where an additional, confirmatory test is performed automatically, reflexively, on a sample that was already collected. This reflex test helps stratify or triage the patient by determining the next appropriate step, such as a direct referral for colposcopy or additional monitoring, based on the results of the second test. In simple words, if the initial primary HPV-based testing or the cytology alone is positive or high grade in cytology, respectively, then a reflex triage testing should be done in the same laboratory specimen. Reflex testing saves time and ensures prompt, appropriate management without recalling the patient for a new sample. Coilocytes are cervical epithelial cells with a wrinkled, racinoid nucleus and a paranuclear halo. They are considered pathognomonic for HPV infection. Recognition of coilocytes is key in pap smear interpretation and helps identify HPV-related cytologic changes. Now let's discuss grading of cervical cytology on pap smears and the appropriate next steps. 1. Low-grade abnormalities. Generally reassuring, may only need follow-up and observation. This includes negative for intraepithelial lesion or malignancy, which is normal cells, so continue routine screening. Atypical squamous cells of undetermined significance ASCUS, which are changes in squamous cells that do not qualify as squamous intraepithelial lesion but are more significant than inflammatory or reactive changes. Cytological low-grade squamous intraepithelial lesion. There are two appropriate next steps for ASCUS and low-grade squamous intraepithelial lesions detected in Pap smear, which are either to repeat Pap smear or to perform HPV testing. Both are appropriate next steps. If HPV positive, then should be followed by colposcopy and biopsy. But, if HPV negative, repeat Pap smear testing in 12 months. Secondly, there are the high-grade abnormalities, which are generally pathological findings requiring further evaluation. These includes high-grade squamous intraepithelial lesion. Atypical squamous cells likely to contain high-grade squamous intraepithelial lesion cells, ASC-H, and atypical glandular cells. Next steps for these high-grade lesions is to refer for colposcopy and biopsy. If biopsy is inconclusive, endocervical curettage may be performed. For atypical glandular cells, if both colposcopy and endocervical curettage are negative, perform an endometrial biopsy to rule out endometrial hyperplasia or carcinoma. This slide focuses on glandular cells seen on Pap smears and how to interpret them. First, typical glandular cells. They are normal glandular cells from the endocervix or endometrium. Often seen if the Pap smear is taken after menstruation, when some cells are shed and trapped in the ectocervix up, especially in the first 10 days after menses. And they are generally low-grade, requiring no further action in women less than 45 years of age. Important exception are women with 45 years or more. This finding in this age group may indicate endometrial hyperplasia or carcinoma, and the next step is an endometrial biopsy to evaluate the endometrial lining. 2. Atypical glandular cells, AGC, are cells that are dysplastic or malignant. They are considered high-grade in all age groups and should always be followed by further investigations. Let's talk about when it's safe to stop Pap smear screening. Women over age 65 who have had adequate prior screening and are not high risk can safely discontinue screening. Adequate prior screening means 3 consecutive negative Pap smears in the last 10 years, or 2 consecutive negative co-tests, Pap plus HPV, in the last 10 years, with the most recent test within the past 5 years. The exceptions are women with a history of CIN2, CIN3, or adenocarcinoma in situ. Those should continue screening for at least 20 years after the abnormality, even if this extends beyond age 65. In women who underwent hysterectomy, no Pap smear is needed if the surgery was for a benign reason, like fibroids or adenomyosis. If the hysterectomy was for a malignant reason, screening should continue routinely, and samples are collected from the vaginal cuff. Cervical histology is also graded as low-grade and high-grade based on the thickness of abnormal cells within the epithelium. The grade in cervical intraepithelial neoplasia refers to how much of the epithelial thickness is affected, not the degree of cell differentiation. Low-grade, CIN1, dysplastic cells are limited to the lower one-third of the epithelium, often just 1 or 2 layers above the basement membrane. Usually reassuring, with a high chance of spontaneous regression. Managed mainly with observation and follow-up. High-grade, CIN2, in which abnormal cells extend into the lower 2/3 of the epithelium. And CIN3, in which dysplasia involves more than 2/3, up to the full thickness of the epithelium, but without invasion. These are not reassuring and require definitive management. Finally, invasive cervical carcinoma occurs when abnormal cells break through the basement membrane and invade underlying tissue. Now let's go over management of CIN based on biopsy results. CIN1, usually managed with observation, since most cases regress spontaneously. If treatment is needed, options include ablative therapies like cryotherapy or laser ablation. CIN2, in young women, observation may be considered, because many cases still regress. In older women, treatment is preferred with excisional procedures. SIN2 is the lowest yield in the NBMEs and least tested due to its vague cutoffs. The focus on SIN1 for observations and follow-up questions and CIN3 and adenocarcinoma for best next approach questions. SIN3 or adenocarcinoma in situ. These always require treatment with an excisional procedure called cervical conization. This can be performed by scalpel and the procedure called cold knife conization, or electrocautery, and the procedure called loop electrosurgical excision procedure. Both are diagnostic and therapeutic, since they remove the abnormal tissue and allow for histological evaluation. Follow-up after treatment. Perform HPV-based testing at 6 months post-procedure. If negative, repeat HPV testing annually for 3 years. If all 3 annual tests are negative, then return to routine screening guidelines. Although cervical conization is both diagnostic and therapeutic, it can lead to important complications. Number 1 is cervical incompetence, insufficiency, weakening of the cervix, which may cause second trimester pregnancy loss or preterm labor. Risk increases with the amount of tissue removed. Number 2, cervical stenosis, narrowing of the cervical OS due to scar tissue after healing. Can cause dysmenorrhea, pelvic pain, and light menstrual flow because menstrual blood cannot flow normally. If severe, may lead to hematometra, amenorrhea, infertility, or recurrent pregnancy loss. Gradual cervical dilation can be used as a treatment. Special note about pregnancy: colposcopy is safe during pregnancy. However, cervical excision should only be done if invasive carcinoma is strongly suspected, because excision during pregnancy carries a risk of preterm delivery. Invasive cervical carcinoma is an important and highly tested topic. Cervical cancers are usually friable, vascular masses on the cervix. Patients typically present with abnormal vaginal bleeding, for example postcoital bleeding, prolonged or intermenstrual bleeding, and postmenopausal bleeding. Key risk factors for the development of invasive cervical cancer that commonly tested are persistent infection with high-risk HPV strains, especially 16 and 18, tobacco use, and immunosuppression, including HIV. Remember, cervical cancer is considered an AIDS-defining illness in patients with HIV infection. The standard treatment is radical hysterectomy in appropriate stages. Most common cause of death, not the cancer itself, but renal failure. This occurs because the tumor invades laterally into the ureters, causing obstruction leading to hydronephrosis and subsequently renal failure. That brings us to the end of our session on Pap smears and cervical conditions. I hope this presentation helped clear up the confusion and gave you a solid, exam-ready approach to this high-yield topic. Remember, mastering these guidelines and next step strategies can easily earn you 5 or more questions on test day. If you found this helpful, I would love for you to check out my educational page Navigence, where we share daily high-yield concepts, NBME-style cases, integrated strategies for Step 1, Step 2, and beyond. Thank you for joining me, and I wish you the very best in your studies and exams. You've got this.